Good morning. Thank you both for coming. Good morning and welcome to the Fetal Diagnosis and Therapy Education session. We'll start with a video tribute to Al Lorimer, followed by a brief history of fetal surgery by Dr. Diana Farmer, and finally our three abstract presentations. I'd like to specifically recognize Laura Galgansky and Nidhi Shahi for their work in creating this video, and I'd like to call them to the stage for recognition for it. So could we run the video tribute, please?
Alfred Lorimer was born on May 30th, 1931, in Washington, D.C., and grew up in San Francisco. He attended the University of California, Berkeley, where he was a champion track and field athlete. While working one summer break at Yosemite National Park, he met his wife, Sandy, and Yosemite became their favorite place to celebrate their anniversary for years to come. During his general surgery residency at UCSF, Dr. Lorimer witnessed firsthand the need for specialized surgical care for children. This lack of adequate care inspired him to pursue further experience in pediatric surgery. Following training at the Columbus Children's Hospital of Ohio State University, he returned to UCSF as one of the first trained pediatric surgeons and established a specialty in California.
So Dr. Lorimer was one of the giants in pediatric surgery. He definitely was the original pediatric surgeon in San Francisco. He came into pediatric surgery in San Francisco at a time when pediatric surgery was new. It was actually before it was a board-certified fellowship, and there were many general surgeons who were opposed of having pediatric surgeons around. But his dedication to children and his advocacy and his just great technical skill eventually won the hearts and minds of everyone in San Francisco and Northern California, and he really became the first academic pediatric surgeon in the San Francisco Bay Area.
For 15 years, he worked alone in his practice, assisted in the office by his wife Sandy, until he was joined by his partner Mike Harrison. Along with a number of enthusiastic pediatric surgeons, Dr. Lorimer helped found APSA. He was the first treasurer and went on to serve on the Board of Governors and ultimately is APSA's 22nd president.
One of the things that people don't know about Dr. Lorimer is that he really was the initiator of the field of fetal surgery.
Working alongside a group studying fetal cardiac physiology, Dr. Lorimer helped develop the first animal model of congenital diaphragmatic hernia, which would lay the groundwork for Dr. Mike Harrison's revolutionary work in fetal surgery. But outside of medicine, Dr. Lorimer had a wide array of passions. He and his wife built the Lorimier winery in Alexander Valley in 1985, and the tasting room was open to the public in the early 1990s. He was an avid sailor and often participated in the San Francisco regattas. Known to take call from his boat using a radiophone, he was beloved by his colleagues and by the many residents and young pediatric surgeons he encouraged and mentored.
I still think of Al often and his passion for life, and I know he will be smiling down on me as I prepare to take a sabbatical year from pediatric surgery and sail around the world in the Clipper 2019-2020 yacht race. So here's to you, Al Lorimer, and your legacy of inspiration, which continues to this day.
Thanks so much. I'd like to invite Dr. Diana Farmer to the stage to give us a talk about the history of fetal surgery.
So first of all, thank you to Laura and the two of you for putting together that great tribute to Al. I saw it the first time and said I was glad you showed it to me ahead of time, because I've got to admit it sort of brings a tear to one's eye who spent time with Al. And I know, because in fact, Mike, you're the guy who taught me how to cry so much, so I know you had the same feeling. So the history of fetal surgery is really the story of Mike Harrison and the legacy that he has brought to all of us in this brave new field. When you think about the evolution of a new field of surgery, you think about the development of the heart-lung machine and heart transplant,
and coronary artery bypass. And all of those developments had so many similarities. First, it involved sort of a brave new thinker who was willing to try new things. Everybody thought it was a bad idea, generally. Then you had folks that were early adopters and started taking credit for the work that maybe somebody else did. And then everybody said, oh, that was my idea anyway. I wish I had done it. So as was true with heart-lung bypass, liver transplant, so was true with fetal surgery. If you think about it, it was only 2 or 3 generations ago that indeed the fetus was shrouded in mystery. I have to also say that all of these slides are Mike's. I thought no better way to give the history of fetal surgery than to use some of those original slides. But this is a great illustration of what that mystery was all about, that you waited and counted the fingers and toes when a baby was born and you hoped for the best. But as technology evolved, along came a new technology. Mike was also privileged to have a great illustrator, Susie Kwan, as part of his career for a long time. And you learn that it's not only the great ideas, but the ability to express great ideas that helps move a field along. And Susie made some of these fabulous things. So along came this disruptive technology, ultrasound. All of a sudden, you could look inside and see everything a fetus was doing. And they do a lot of things in there. It's really amazing. But what it showed was that there were unexpected things. Ultrasound was really first used to supplant pelvic radiology in order to determine whether or not a baby was breech or not. Remember your grandparents, people who were old enough? Those were the things that ultrasound was used for originally. But there were many perspectives that needed to come together in order to make fetal surgery a reality. So those ultrasonographers who were looking maybe to see if it was a boy or a girl occasionally would see a defect, but there was nothing they could do about it. It was like, oh gosh, something's different. And of course you have to remember that early ultrasonography was not nearly as sophisticated as it is now with our high-resolution CT and imaging. Pediatric surgeons typically would see a defect, do a great job fixing it, and the classic one, of course, is diaphragmatic hernia, but in fact, it was often too late. We could do a great operation, but those babies died anyway, because obviously there was some problem with the development of their lungs. Mike had the additional opportunity to spend some time in Sweden and the Nordic countries where they had a fabulous birth registry. So that gave him the opportunity to coin the term the hidden mortality. We at children's hospitals, particularly referral children's hospitals, only saw those babies that survived gestation and survived the delivery room and a transport to get to a children's hospital. But with the great birth registries and death registries that existed in a small country, they knew everything about the natural history. And so he was able to define that term that is now part of our ordinary lexicon, the hidden mortality associated with defects, to see that if you take from the time of original diagnosis in utero, that there were a number of patients who were not even part of our analysis at the time of presentation at a children's hospital. So then what was required? This wasn't enough to just see that there were babies dying in utero. It required rigorous thought, because all of a sudden the stakes were going to be high. So in addition to asking the question, would it make a difference to do it before birth? Because obviously at the time nobody knew. That required studying the pathophysiology in rigorous animal models, and it also required defining the natural history in utero. Because think about it, we all know now that you often see these big cysts in babies, in their lungs, in all kinds of places. Imagine if we had just started by sticking needles in all of those. We know half of them go away. So the restraint that was necessary in the beginning to just observe, to just learn, was key. And Mike was blessed with an army of dedicated and creative thinkers to help him with that. So in the beginning, it was a very simple concept that a simple anatomic defect would lead to disastrous physiologic consequences. And I don't think that fetal surgery could ever have evolved in any place but UCSF. It couldn't have ever happened in a freestanding children's hospital. It was the mix of neonatologists, ultrasonographers, perinatologists all together. And we were blessed by the privilege of not having enough space. It was a scrunched up, small hospital. The OBs were right next door to the neonatologists. You couldn't help but bump into people every single day. Now we complain and we want more space, but it was actually the fact that everybody was sort of glued together that made this happen. It couldn't have happened in any other location. As the video says, Al really did do the first diaphragmatic hernia animal study and sort of primed to the pump and was ready when Mike arrived as a fellow. And they were great partners. It's amazing to think that the two of them covered San Francisco entirely by themselves for about 2 decades before anybody else came. And in that same time, all this great scientific work was done as well. I mean, think about it. You had every other weekend off. What else was there to do? But it took 3 decades of discovery. It took a lot of hard work. It took a lot of great stories. The first and most important issue was maternal safety because, of course, the fetus was inside the mom. So the mom became an incredibly important part of this story, and there were a number of incredible lessons learned. The ethics became an entire field for other people, and this is one of the great stories no one knows, but there was a spy in the camp for about a year. Mike was always welcoming to anyone to come, and it turned out this person was very much against fetal surgery. Another great commentary to Mike's legacy is that this was at a time when the issue of pregnancy termination was roiling again in this country, which I guess it is coming back. But Mike very carefully steered away from the issue of whether or not a fetus was a person. This was a big debate. It was on the front page of the New York Times, in the New York Magazine, all over the news. Mike just focused on the fetus as a patient, and I think that that is a great lesson for all of us. He focused on the science. He stayed out of the debate that was raging at the time. I would say the Right to Life community was very much against fetal surgery. It was against the notion of violating the sanctity of the womb. Fast forward another 30 years, the Right to Life community is a strong supporter of fetal surgery as an alternative to pregnancy termination. So I think there's a lesson there for all of our future scientific endeavors. So many new things that are happening in terms of in vitro fertilization and the Dolly test tube babies, all of these things, that social mores change over time. Focusing on the science allows the field to continue. So the incredible work on balancing the risk-benefit for the mother, who was truly an innocent bystander, another term coined by Mike and now used in many other arenas, was key. This person undergoes an operation for which they get no benefit. Very similar to the ethics of living-related liver transplant, I would say, and similar degrees of ethical concern and weight. So here's the problem. The uterus, it's basically a big bag of blood with fluid inside. You know, how do you get in safely? How do you not have the mother bleed to death? How do you preserve the pregnancy? How do you keep the amniotic fluid going? All of those things were unknown. So, of course, the only way to test this was in the most rigorous animal model, which was the non-human primate. And although my stories are not quite as impressive as Alberto Peña's the other day, I'll have to say there were many things that now when you look back and you realize social mores have changed in standards, but I do believe that there is a photograph of transferring with Phil Glick and Scott Adzick, one of the primate patients in the back of a station wagon over to, I think it was the VA, to get additional imaging done, something you probably couldn't do today. So you can see them in the back, hand ventilating this primate patient over there. Another story that people don't know, one of the most important discoveries that was made by working hard in the non-human primate model was the fact that the staplers that were being used at the time, so the typical GIA, TA staplers, the metal staplers, acted like an IUD. And the monkeys could not subsequently become pregnant. If that work had not been done, it would have taken years, generations of women to understand what was going on. But we were able to define it, and of course, a new special absorbable stapling device was developed by Mike and his collaborators, I think at the time with US Surgical. They've undergone many changes. Of course, no one patented anything at that time. No one thought about patenting things. It's a good thing, because what would we have done if Mike had become rich? So, he thought of it. Mike thought of all of these things, many things, which I will show you. So, fast forward, where are we today? This idea, which was heretical at the time, has now saved the lives of thousands and thousands of babies. Tumors, lung lesions, airway obstructions, diaphragmatic hernia, heart disease, spina bifida, urinary obstructions, twin-twin transfusion, led the way for in utero stem cell therapies and in utero hemoglobinopathy work. All of that sprung from the courageousness of thinking about a new way of treating patients. So this is just a slide of a fetal surgical patient, but it illustrates lots of things. First of all, the backbiting clamps, also developed by the engineer that was always seemed to be around in the operating room, and Mike could say, we need something that bends this way or goes this way, and we need those clamps to be out of our way and to take the corners of where we put the stapler through. You can see those absorbable staples still used today. We also learned, do not mess with the umbilical cord. So the mantra for a general surgeon is don't mess with the pancreas. The mantra for a fetal surgeon is don't mess with the umbilical cord. We learned that, of course, the hard way. Here you can see that umbilical cord finds itself in very inconvenient locations. In fact, you wonder how any fetus survives after you do a few fetal operations and you realize that umbilical cord is wrapped all over the place. Here's an example of a sacrococcygeal teratoma. And the issue also illustrates here that it's all about changing the pathophysiology, not necessarily doing the same operation or the definitive operation, but just changing the pathophysiology that makes it a problem in utero. We only do these operations if the fetus develops fetal heart failure. Otherwise, you have all taken care of giant sacrococcygeal teratomas. If it's not causing in utero distress, then there's no reason to do it before birth. And these were the principles that were articulated at the first meeting of the International Fetal Medicine and Surgery Society, IFMSS, which I can finally say right after 30 years, Mike. 1982, they all got together from people from all over the world that were thinking about these kinds of things and made some decisions that maternal beneficence was the most important thing to think about, that you had to have a good physiologic rationale and ideally studied in an animal model, that in theory it should only be a singleton pregnancy because you didn't want to risk the life of now 3 people there. Although we violated that in the very beginning, and in fact, Mike's first patient his first patient who not only survived fetal surgery, but survived, is now probably 30 years old. And we had the privilege of inviting that young man back to the 25th meeting of IFMSS, and that was pretty extraordinary. He, of course, doesn't remember a damn thing, right? He was a fetus, but his mom remembers it very carefully. And those brave mothers, and Mike always gave credit to those women, they were the true pioneers who were willing to undergo this when they had no idea what the outcomes were going to be for themselves and for their baby. And one of the great privileges was hearing Mike counsel these women. First of all, if he hadn't been a surgeon, used car salesman might have worked out just fine. He could talk anybody into anything, but it was always the truth. It was always the truth. So, raise your hands if you've never seen a fetal operation in real life. Okay, there are enough that I'll show the next video. Because this is one of the more dramatic videos of fetal surgery. Everybody takes videos of fetal surgery, but what's great about this is how many principles it shows. So here's that special clamp that was the special stapler that was utilized. I have to tell you, I now had to retire from fetal surgery because the damn thing is so hard to squeeze. You know, you've got to get somebody like Dr. Hirose who can make sure it's always down tight. This was a fetus who not only had a huge teratoma, but it was also causing fetal heart failure. These are tiny operations. You can't tell what you really need to do, and you don't know what the outcome's going to be. This fetus was going to die otherwise. We took one carotid and both IJs. We never saw anything that really looked like a thyroid. The hard part, of course, is getting those little suckers back in. You actually need your anesthesiologist to make sure that you have great uterine relaxation. If that's not working for you, the whole operation doesn't work. That red rubber catheter shows restoring amniotic fluid volume. We did a lot of work to find out that lactated ringers works just great. How to get a watertight closure, and how to then make sure. And there's that baby born later on. We also invited him to come back at about age 5 to a grand rounds. And of course, he was just running up the aisles just like any other normal 5-year-old kid. It's really pretty extraordinary. So this was Nancy Pelosi opening the first fetal treatment center about 25 years after all this work was being done, but now they actually had a location to make it work. But the greatest legacy of the early days of fetal surgery in the history of fetal surgery were the people that were spawned from Mike's lab, most of whom have gone on to start fetal treatment programs around the country and around the world. Scott Adzick, as you all know, who really came back after his lab time with Mike to work as a partner and then moved to Philadelphia, was the first sort of branch point on the fetal surgery tree. Phil, I think that's going to be one of the books you have to do at some point. And then the following generation as well, who have really gone on, almost every single one of these folks, to start a fetal program in their region, to bring this therapy now, not from just being an experimental, isolated thing, but bring this great life-saving work to people all around the country and now around the globe. A few of us came on the scene as partners, not lab folks. Actually, when I tried to join Mike's lab, it was already too busy. He sent me to the poor guy down the hall who didn't have anybody in his lab. Unbeknownst to me, that was 3 years of fabulous training in cell therapy, immunotherapy at the time, which led the way for me to get involved in stem cell therapy later on. Mike always took care of people, even if he couldn't do it directly. He always had an open heart and an open hand for folks along the way. The famometer has now been found in many places. We spent a lot more time in the crash and burn neck of the woods for this, and for all the great successes, there were a million failures. Mike exemplifies the words of Winston Churchill that success is nothing but going from failure to failure with undiminished enthusiasm, and that, of course, was Mike Harrison. Here you see him getting an award from the glamorous Jamie Lee Curtis. I don't exactly know the story behind the pink wig, but with the Ronald McDonald House. And although I can't come close to being Jamie Lee Curtis, Mike Harrison, I'd like you to come up to the stage right now so we can all thank you for the great contribution that you have made to the history of fetal surgery. You know, it's all true.
Great.
Yeah, to the front. My hands are freezing.
Can I say something?
Yeah, you sure can. All right, but you have to do it by whispering in my ear loudly.
Good. So thank you for that. But thank you, Diana and team, for that tribute to Al.
Yeah.
It did to my
Me
eye.
too.
So it reminded me of two things. I love the way you pointed out. The reason I went to San Francisco was because Al was there, and he had introduced the fetal lamb model. Fabulous. And it reminded me of something I don't think any of you have heard. When we would walk onto the pediatric floor to go make rounds together, the nurses and all the folks would say, "Here comes Big Al, the patient's pal."
That's right. Thanks, Mike. All right. So with that, we're going to go on to the session put together by these two great guys and about some of the new developments in fetal surgery. Thank you for the privilege.
Thank you, Diana, for that great talk. I'd like to move on to our abstracts.
So the first abstract is discordant prenatal ultrasound and fetal MRI and CDH, wherein lies the truth, presented by Kim and colleagues.
Thank you for the opportunity to present. We have no disclosures. Sorry, let me find this mouse. I'd like to start with a real prenatal consult we encountered recently. A young mother was referred to our fetal diagnosis and treatment center after routine prenatal ultrasounds identified findings suggestive of a left-sided congenital diaphragmatic hernia. The LHRs range from 1.4 to 3.2 throughout gestation, and at 29 weeks, the O to E calculated to 77%, reassuring. But fetal MRI from the same date at 29 weeks measured a total fetal lung volume of only 3.7 milliliters, with an O to E of only 6.9%. We counsel expectant parents with CDH that cases fall on a spectrum, and where their baby falls on the spectrum is dependent upon factors such as the predicted lung volumes and liver position. But when findings can be so discordant between prenatal ultrasound, which would place this baby in a mild category, and fetal MRI, which would place this baby in the severe category, what do we tell our patients? To address this question, we decided to take a closer look at our cases of prenatally diagnosed CDH over the last 8 years. We identified and did a retrospective chart review of our cases of isolated left-sided CDH that had an MRI performed within a week of corresponding ultrasound. We excluded those with chromosomal and cardiac anomalies. Each case was assigned two image-based prognostic categories, one based on ultrasound that incorporated both the O to E LHR and the liver position, and the second based on the MRI total fetal lung volume. For example, a fetus that had an O to E LHR of 38% and liver up would be assigned a moderate prognostic category per ultrasound. If the same fetus were to have an O to E TFLV of 38%, the fetus was assigned the mild prognostic category by MRI. Of a total of 42 patients, we found 17 or 40% had discordant prenatal image-based prognostic categories. And the majority, 76%, MRI assigned a higher acuity of disease. Now, this cohort of the discordant prognoses was too small for a statistical analysis. However, just looking at rates of ECMO and survival, our outcomes appeared more consistent with the MRI prognosis. We next looked at the larger cohort of 42 to compare their prenatal image-based prognostic categories with postnatal outcomes, post-discharge needs, and the CDH study group clinical prediction tool for mortality. In the larger cohort, both ultrasound and MRI demonstrated significantly different survival rates per category by Pearson's chi-square test. However, rates of ECMO utilization, surgical repair, and frequency of defect type were significantly different only by MR category. In subset analysis of the 24 survivors, both ultrasound and MRI differentiated significantly for lengths of stay and post-discharge needs as home O2 and pulmonary hypertension medications. When we assessed the very well-validated CDH study group mortality risk category against our prenatal image-based categories, outcomes were, we found significantly more agreement between, Let me go back. We found significantly more agreement between the MR category and the CDHSG risk category, with a kappa score of 44% and a p-value of 0.03. In ROC curve analysis, we found two outcomes in which the O to E TFLV discriminated more significantly than O to E LHR, and that was for identifying survivors with an AUC of 0.92 versus 0.77, and differentiating between larger and smaller defects with an AUC of 0.91 versus 0.73. In summary, we found that discordance between prenatal ultrasound and fetal MRI occurred with relative frequency. In our cohort, MRI appeared to more accurately correlate with postnatal outcomes. Currently, a multi-institutional survey amongst NAFNet centers is underway to assess current practices for the prenatal evaluation of CDH. A major implication for these studies is a potential role for fetal MRI in the evaluation for prenatal intervention. I'll move on to some audience response questions, if you guys have your clickers. In what percentage of cases were prenatal ultrasound and fetal MRI prognoses discordant? %, 40%, 60%, or 80%? Excellent, 40%. Next, O2E-TFLV was more discriminatory than O2E-LHR for which of the following? ECMO use, survival to discharge, type A and B defects, 1 and 3, or 2 and 3? So it's actually 2 and 3. So survival to discharge and differentiate between smaller and larger defects. Thank you, and I'd be happy to take questions.
I think I see Daryl coming to the microphone.
Yeah, Daryl Cass, Cleveland Clinic. Thanks very much for sharing your data. It sounds like you came to similar conclusions as we did when we looked at our data from Texas Children's Hospital. But I guess it's a really complicated area. Measuring LHR has been well studied about the variability in the accuracy, and any one observer will get a different measurement in multiple different studies, and then multiple observers get different measurements with the same patient on the same day. And I have a question about MRI accuracy too. There were a lot of ways people were measuring lung volumes. It seems like we may have settled on total fetal lung volume, but I was like looking at the example of your picture, and I don't know if that was the exact case that you said had a lung volume of 10 or 14%, because it didn't look like that to me. It looked like a lung volume of about 30% in that particular case. But I wonder about standardization amongst radiologists of how we're evaluating these studies, because if we are all getting variability in measurements, and of course there's variability in care, it's like obviously there has to be a multi-institutional study, but we also have to have standardization of how we're doing each of these techniques. And so how are we going to resolve all of this? Thanks very much.
Thank you very much for your question. I think you raise an excellent point, and I think the current NAFNet survey that's going to, that is collecting data that will help us identify what our current institution's doing, and then we can also compare findings as well. In our institution, we have one MR radiologist, one radiologist that's reading all of our MRs, and so in that sense, we are able to eliminate the inter-rater variability amongst MR readings. But with our MRI O2E-TFLVs, we were measuring the lung volumes excluding the pulmonary hyla. But thank you for your comment.
Well, Latoya, currently in Houston, Texas, heading to Columbus. I really enjoyed your talk. To follow up on what Dr. Cass said, I think one of the aspects that may be easily missed or mismeasured with ultrasound is actually including the spleen in the measurement of the lung. And I think that's really where the MRI is able to discriminate, and which is why most of the time you find that the MRI will find a more severe category. Because the spleen many times depend on the sophistication of the MRI or of the ultrasound, or even the ability to distinguish it. Many times the spleen gets measured as part of the lung volumes, which would account for a higher number than you would actually see. We found that MRI, of course, is a little better to discriminate those different modalities, and therefore, as you found in your study, would give you a value that confers more severity to the lung volumes. But I think doing this in a multi-center study may be able to validate that, but I truly enjoyed your study.
Thank you very much for the comment. Actually, it's an interesting point. It has been published that the fetal lung is difficult to discriminate on ultrasound, especially even differentiate between fetal lung and liver. The case that I presented, actually, what we found on MR that we did not realize or could not appreciate on ultrasound was that not only did the baby have a left-sided CDH, but on MR we found that also the baby might have had a right-sided diaphragmatic eventration. So what likely happened on ultrasound was that and the liver rode very high in the right thoracic cavity. So what likely happened was that what we were measuring as lung for the LHR on ultrasound was actually the liver. Thank you for the comment.
I have one question. So in addition to the debate between the use of ultrasound and MRIs in looking at these fetal anomalies, have you identified in your cohort some of these patients where an anomaly was missed on the ultrasound and you picked it up on the fetal MRI? And would that have changed the way you managed the baby?
Yeah, thank you for the question. Not in our cohort. So we had limited our study to babies that had a diagnosis of CDH and had an MRI and ultrasound within a week. And we'd excluded those of cardiac anomalies and chromosomal anomalies. And so we didn't find any surprises within our limited cohort, but that's definitely something that would be interesting to look for in the larger NAFNet survey as well.
Hi, Joe Davidson from St Thomas's in the Evelina in London. Just an answer to that question, there's a big study called the iFind trial and the iFind 2 trial running where concomitant MRI and ultrasound are being done. And we as a pediatric surgical team have gone and looked at this data. The neurologists and the cardiologists have gone through it with a fine-tooth comb, and we're finding actually that quite a significant number of these babies have got GI or body anomalies that were missed. And I think it's a big advocacy for us to start doing MR on more of these babies.
Thank you very much.
I'd like to add that one of the reasons this paper was of interest was for those of us that are starting fetal centers. Not everyone has the luxury or sort of the ability to have truly expert ultrasonography. And I would just quote our radiologists in describing ultrasound versus cross-sectional imaging, and that ultrasound's like shining a flashlight in a dark room, and cross-sectional imaging turns on the lights.
Thank you.
Thank you.
Thank you.
The second abstract is survival following fetal intervention for in utero renal failure, presented by Dr. Riddle and colleagues.
Good morning, and thank you for the opportunity to present. My name is Stephanie Riddle, and I'm a neonatologist at Cincinnati Children's Hospital and affiliated with the Cincinnati Fetal Center. I'm representing a large group today and presenting our center's outcomes in pregnancies affected by fetal renal failure. I have no conflicts of interest. Fetal renal failure with etiologies that include obstructive GU anomalies, primary renal dysplasias, and agenesis ultimately results in abnormal amniotic fluid, and this has historically been a lethal condition due primarily to pulmonary hypoplasia. Fetal interventions for those with obstructive anomalies aims to restore normal fluid by bypassing the obstruction and allowing native fetal urine to repopulate the amniotic space. However, in cases where the kidneys no longer or never produce urine, these interventions are not options to salvage pulmonary development. Ultimately, predicting those fetuses that would benefit most from fetal intervention would be ideal. However, prediction of pulmonary hypoplasia remains largely based on clinical parameters extrapolated from other diagnoses and poorly predictive outside of lethality. Amnioinfusion, which is restoration of amniotic fluid with IV crystalloid solutions, was first utilized by obstetricians to relieve cord compression leading to fetal distress, and has been trialed largely in Europe in PPROM patients to attempt to increase perinatal survival and decrease pulmonary hypoplasia. Animal models have shown that serial infusion in renal oligohydramnios decreases pulmonary hypoplasia, and a number of case reports have been published recently that describe both percutaneous and amnioport techniques for restoration of fluid, including by our own center. Cincinnati Fetal Center offers serial amnioinfusion by both methods to attempt to increase survival and decrease pulmonary hypoplasia, in addition to the more traditional urinary diversion techniques for bladder outlet obstruction. In describing our outcomes, we hypothesized that while fetal intervention, mainly with serial amnioinfusion, will increase perinatal survival, that there will remain significant neonatal morbidities associated with end-stage renal disease, as well as risk of pregnancy complications following these interventions. This retrospective review focused on our center's first 3 years of experience with serial infusions from 2014 to 2017. We described maternal and neonatal morbidities, neonatal survival, and pregnancies both with and without aggressive fetal intervention. 235 pregnancies were evaluated based on a fetal diagnosis of renal or GU anomalies, and after these exclusions yielded a population of 56 mother-infant dyads to be analyzed. This population was largely a referral population seen in the second trimester with early occurrence of oligo or anhydramnios. Multiple studies have shown that early second trimester oligo results in the highest risk of lethal pulmonary hypoplasia. IUFD, or fetal demise, is known to occur at higher rates in these patients and was seen in approximately 20%. We had a large population of bilateral renal agenesis, as few centers were offering fetal intervention during this period. This was a motivated population, with greater than 60% of patients opting for serial intervention at our center, with none of these interventions being solely genetic amniocentesis. Approximately 20% of patients had undergone a procedure or multiple prior to referral to our center, including vesicocentesis and even serial infusion with referring providers. Patients began interventions in the mid-second trimester soon after evaluation. And for those who opted for serial amnioinfusion, they received a median of 7 infusions during the pregnancy. As just mentioned, the most common procedures were serial amnioinfusion, either by percutaneous route or via amnioport. While some patients underwent vesicocentesis, shunting, and fetal cystoscopy, this largely represents a population with primary renal disease or end-stage renal failure, not amenable to diversionary procedures. Preterm labor and fetal distress were the most common indications for delivery. Based on their desire for aggressive postnatal interventions, the majority of patients were delivered in our local area. Infants were a late preterm population, which raises additional challenges with specifically respiratory management, but also in consideration of weight thresholds for feasible and successful performance of dialysis. At our center, a minimum weight threshold exists for offering dialysis to neonates, which is not typically met until 32 to 34 weeks gestation. Looking at survival, overall, in this high-risk population with early fetal renal failure, there was just under 50% survival at 1 week of life. We chose these cutoffs as survival to 7 days likely reflects pulmonary status, while survival to 30 days and discharge reflects feasibility to dialysis and associated complications. Those with obstructive GU anomalies and resultant renal failure had the highest survival to discharge. However, those with primary renal dysplasia had better than expected survival similar to the BU population. We had no survivors to discharge in the population with bilateral renal agenesis. Looking beyond survival, those who opted for aggressive interventions required an average of 14 days on mechanical ventilation, and pneumothorax was common, reflective of the idea that even if lethal pulmonary hypoplasia can be mitigated, pulmonary maldevelopment is likely still occurring. Hypotension was common in this population and nearly universal in our longer-term BRA survivors. We believe this is reflective of the absence of normal renal tissue to participate in hormonal pathways critical to blood pressure homeostasis. For those that survived to receive dialysis, most started within the first week of life and received some combination of hemodialysis or modified aquapheresis at our center until PD catheter maturation and healing has occurred. We then compared the natural history of those who have elected not to pursue fetal intervention versus those that did. Mothers that had an intervention had a high complication rate ranging from minor complications, post-anesthesia issues, chorioamnion separation, inability to complete the procedure, subsequent preterm labor or rupture of membranes, and others. Live birth was nearly equal between interventions versus none, and survival to each time point was higher in those that opted for fetal intervention. Most outcomes did not reach statistical significance, likely due to the size of our population. We acknowledge a number of limitations exist with this data set, including its retrospective nature, small population, and the referral bias based on our fetal centers population. In conclusion, fetal renal failure, regardless of etiology, results in a high risk of fetal or neonatal demise, especially within the most critical first week of life, reflective of the high incidence of pulmonary hypoplasia despite aggressive interventions. Maternal and pregnancy risks exist with these invasive interventions, and while survival in all three diagnostic categories was greater with less lethal pulmonary hypoplasia, survival to discharge remained challenging due to the ongoing difficulties with cardiovascular stability and neonatal dialysis. As a multidisciplinary renal interest group, we remain interested in a number of facets of these patients' care. We are currently modeling fetal lung volumes obtained from serial MRI to assist with prediction of survival and pulmonary hypoplasia, and hopes that this will allow more targeted approaches to intervention. We are also studying outcomes beyond survival, including neurodevelopment and transplant outcomes in these patients. There are two ARS questions. Fetal intervention for in utero renal failure shows proven benefit in survival and can be broadly adopted. Hopefully that's an easy one. That is false. Oops. The second question is, pulmonary maldevelopment is the main, and perhaps I should have said only, risk faced by fetuses and neonates with in utero renal failure. That's a bit of a trick question. It is not the only risk. Certainly cardiovascular instability and the difficulties of neonatal dialysis remain significant barriers to these patients' care. I thank the Fetal Therapy Committee for the opportunity to present these findings and welcome any questions.
I have a question. So, because of the complexity of all the diagnoses that can present with fetal renal failure, have you thought about the national trials to conduct this in a rigorous fashion?
Yes, absolutely. It has been a very big discussion at our centers and across NAFNet in general about participating in these trials. Certainly it's a large group decision, but one big concern that we have is still the unknowns and the difficulties with neonatal care, that while, as you sort of insinuated earlier, the fetal therapy can prove pulmonary survivorship, the difficulties in cardiovascular care and neonatal dialysis still remain really big barriers to survival in these infants, not just to NICU discharge, but to transplant. And so it's something that we absolutely think needs to be studied in a rigorous manner in a larger group.
Daryl Cass, Cleveland Clinic. Thank you very much for sharing your data. You guys have clearly been leading care for renal problems, I would say, in the last couple of decades, although that was the first open fetal surgery that Mike Harrison did in the development of the field. I guess my question is, you included two populations of patients that I think are quite different, like the males with the posterior urethral valve and the big bladder, which might benefit from shunting or cystoscopy or other interventions. I think that the prognosis in that population of patients, I think, is really improved, although I'm not sure the data necessarily proves that. And probably because of our ability to care for those neonates in the newborn period has clearly improved, and our ability to deal with respiratory problems with more gentle ventilation and surfactant and things like that have led to improved outcomes. But I think it's a different population than renal agenesis. And yet the two are included. And obviously the statistics on your study aren't statistically significant to the 0.05 level, but it shows a benefit. But I think it's really quite cloudy to include those two populations. And the next parenthetical statement is, a child with congenital renal failure, if you're a posterior urethral valve, usually they still make urine. Usually going on dialysis can often be delayed, but the renal agenesis patient, they have to have renal replacement right away at minute 1 after birth. And congenital renal failure is a bad problem. It's hard to replace the renal function in those patients. And I just wonder what the role of the nephrologist is in carefully counseling all those patients that families are choosing for intervention. Thanks very much.
Yeah, thank you for your questions. I'll address the first point first. We included patients with BOO with the highest risk, so those that were not amenable to just simply urinary diversion. So many patients, while they might have undergone a bladder shunt, ultimately then did not produce urine and underwent infusions as well. So we had a few mixed population. But your point is absolutely well taken, that BOO and BRA are not the same beast at all. To your second question, pediatric nephrology plays a big role in our counseling with families. We typically will meet with families twice, at least in the pregnancy, in a formal sit-down team meeting format, and pediatric nephrology is a big part of that conversation to explain the intricacies and the timeline, as you insinuated, of dialysis and its complications.
This is Oscar Gomez from Spain. Thank you very much for your quite interesting presentation. Do you think that in your patients we can use another technique to improve the lung development, like for instance tracheal occlusion as well?
One of the pillars of neonatology, Alan Job, who is in Cincinnati with me, actually proposed that very thought. Why don't we just occlude the trachea in these patients? And he said it in a bit of a blasé manner, but the point's well taken. Are there other therapies that could be pursued in this population? And while that's not something that our center is currently looking at, the question absolutely stands, and it's a good one. Thank you.
And the last talk is the in utero diagnosis of colorectal cyst. Can postnatal imaging predict who might benefit from early intervention? Presented by Dr. Cochran.
Hello, my name is Elizabeth Cochran. I actually just acquired the doctor status about a week ago, so still trying to get used to that. Thank you so much. Please. So thank you so much for allowing me to speak today at your forum. I'm going to be talking a little bit about the in utero diagnosis of colorectal cyst and whether postnatal imaging can predict who might benefit from early intervention. Sorry, I'm doing the same thing. I did the same thing. I have nothing to disclose. The prenatal diagnosis of colorectal cyst is uncommon, and the standard practice has been to delay cyst excision to 6 to 8 months of age in order to avoid potential complications related to surgery during the neonatal period. The majority of these patients remain asymptomatic throughout infancy. However, a subset of patients do develop cyst-related complications early on, typically during the first month of life. What we sought to determine in this study was whether the imaging obtained in the immediate postnatal period may be used to predict the clinical courses of these infants after they are born. Following IRB approval, the records of patients with a prenatal diagnosis of colorectal cyst from 4 large fetal centers in the United States from 2000 to 2017 were obtained. The charts of 42 patients with a prenatal diagnosis of colorectal cyst were reviewed. Of those, 19 were excluded due to postnatal diagnosis revision, cyst resolution on initial postnatal ultrasound or IPU, a lack of cyst measurements on IPU, or a lack of follow-up postnatally. 23 patients had the diagnosis of colorectal cyst confirmed on IPU, and they were included in this study. The IPU cyst measurements that we utilized in this study were recorded in the longest dimension and were recorded by trained pediatric sonographers. Then imaging, clinical courses, and operative outcomes were compared among patients. So first we sought to better elucidate what the clinical courses of these patients were. And what we found was that 23 of the 23 newborns who had a prenatal diagnosis of colorectal cyst that was confirmed on IPU, it's hard to see from over here, 5 of them developed symptoms during the neonatal period, all before 19 days of age. The range we saw was between 16 and 19 days old. 18 patients, or 78.3%, remained asymptomatic. So we then sought to relate the cyst size on IPU to the presence or absence of symptoms during the neonatal period, which, as shown by the dot plot here, revealed an inflection point at 4.5 centimeters. So with that inflection point in mind, we tried to see where patients fell in regard to that threshold of size on IPU. 18 patients had a cyst less than 4.5 centimeters on IPU, of whom 16 remained asymptomatic throughout the newborn period. 5 patients had cysts greater than or equal to 4.5 centimeters on IPU, and 3 of those patients developed symptoms all within the first 19 days of life. This association between early symptom development and the presence of a cyst greater than 4.5 centimeters in size on IPU was statistically significant with a p-value of 0.048. So we found that a colorectal cyst greater than or equal to 4.5 centimeters on IPU is highly specific and 60% sensitive to the development of cyst-related complications during the neonatal period. So in conclusion, we feel that the prenatal detection of a colorectal cyst is very beneficial to these patients. One, because it allows for immediate postnatal evaluation, both with physical exam and, most importantly, perhaps with abdominal ultrasound, that allows for a better clarification of the diagnosis as well as the opportunity for early intervention if it is needed. We found that the presence of a cyst greater than or equal to 4.5 centimeters in size on IPU is associated with symptom development in the first month of life. And we feel that those infants who are deemed to be at increased risk for early symptom development would benefit from intervention during the neonatal period. So as such, our recommended management of infants with prenatally diagnosed colorectal cysts is as follows. To begin, all patients with a prenatal suspicion for colorectal cysts should undergo immediate postnatal evaluation, including an abdominal ultrasound. If the patient is found to have a cyst present and that cyst is greater than or equal to 4.5 centimeters in size, we recommend that they be considered for cyst excision during the first 2 weeks of life, preferably. And then if the cyst is present in less than 4.5 centimeters in size, the cyst excision can be delayed until 6 to 8 months of age with observation. So, quick couple of questions for you guys as well. Sorry for the pop quiz. So in this study, what findings on postnatal ultrasound are associated with cyst-related symptom development during the neonatal period? All right. Great job. Excellent. Okay. Perfect. All right. Next up, in this study, at what age did the symptomatic patients first tend to develop cyst-related symptoms? Excellent. Yes, within the first month of life. That's correct. Actually, within the first 19 days is what we found. Okay, and finally, our last question. What is the recommended management per our study of a newborn with a 5.3 centimeter cyst on IPU? Terrific. Thank you so much again for the opportunity to present today, and thank you to my mentor, Dr. Schindel, and my wonderful co-authors who helped guide me through this process. Appreciate it. And I'll take any questions.
Hello. Hi, this is Bob Cowles from New Haven. Thanks for your presentation. I'm not sure how which patients you ended up excluding, but from your presentation, the thing that worries me is that we know that some children with prenatally diagnosed cysts ultimately have biliary atresia, and that in that case the size of the cyst doesn't necessarily matter, but the presence of jaundice or an elevated direct bilirubin. So per your algorithm, a small cyst, someone based on your algorithm may say follow up in 6 months, and then a yellow child shows up. So the question is, how do we identify the biliary atresia patients with a cyst? And also because those are the patients that probably do the best after an earlier Kasai procedure. Thank you.
Absolutely. Thank you so much for your question. Yes, so of the 9 patients we excluded due to diagnosis revision on their initial postnatal ultrasound, 4 of those patients were biliary atresia patients. So that's really one of the main reasons we feel that this immediate postnatal evaluation is so key in sort of dictating how we manage these patients. So they were able to determine on their initial evaluation, both as a combination of their physical exam findings, in some cases jaundice or the development of pale stools early on, or the findings on their initial postnatal ultrasound that they felt it was a case of biliary atresia with a cystic component rather than a true colorectal cyst. And in this study, those patients were excluded.
The only problem I see with that is that many of those findings of jaundice, they're really not there at the initial, if you're doing an ultrasound in the first couple of days of life after birth, those kind of more obvious findings that there is biliary atresia may not be present.
Sure, thank you.
In the interest of time, we're going to have to cut the questions.
Okay,
Sorry.
no problem. Thank you. Appreciate it.
I'd like to thank all of our speakers for a great job in their presentations, and I'd like to give a special recognition to Drs. Aaron Perrone and Rony Marwan for keeping the Fetal Committee going, and specifically mention that Aaron has completed editing of the new fetal handbook, which is now available online and will be in press hopefully in the next coming months. So thank you so much to both of them.